Welcome, friends of the Retina Channel podcast, to another episode of this series. For those of you who are new to the podcast, this is a journal club, and every month or so we bring you an article to discuss its findings with the author of the article. And I'm your host, Dr. Kayvon Kushan, and today's article is going to focus on the use of perfluorocarbon heavy liquids in retina surgery, specifically for repair of retinal detachments. Dr. Saleh is our senior author of the study, and he's joining me from West Africa, from Ivory Coast, although he's French and his education and all the academic promotions have been in France, but for the past few years he has been living in Ivory Coast and building a new eye hospital and providing eye care for a local population. Well, Dr. Saleh, as I said, he's from France. He did his residency in ophthalmology at the University Eye Department of Strasbourg. He has done a research fellowship actually in Bascom Palmer University in Miami, Florida. He also got a PhD at the Pasteur University of Strasbourg, France. And prior to his move to Ivory Coast, he was the head of vitreoretinal unit of the ophthalmology department of Besançon University Hospital in France. I apologize if he may still be the head of that department, but I know he lives in Ivory Coast right now. He's actually our first guest from Africa to the podcast since 2018 when we started the podcast. It's the first time from Africa. I am thankful to him. Well, without further ado, here's the conversation with Dr. Saleh.
Hello, Kevin.
Hello. Hi, Professor Saleh. How are you?
Nice to meet you.
Nice to meet you as well. Well, thank you very much for coming to Retina Channel podcast.
Thank you.
Well, you are my very first guest since 2017 that I'm connecting to in Africa. I know you did most of your education, everything in France, but you're actually in Ivory Coast now. And so congratulations for connecting me to the African continent.
Yes, it's a quite interesting time, and Africa is changing very fast, and I think it's interesting to mention it.
Yes. So, I mean, I have your bio, but I'll go over it as well. But just to summarize it, you did everything in France, including the study we're going to talk about. But you recently moved to Ivory Coast to establish a new program, like new ophthalmology program. Is that correct?
Actually, I am French, and I was appointed full professor in France, and I had a very interesting medical team, and it was very exciting. But at one point, just before the COVID situation, everything was blown, and we decided to change a little bit our life, and I decided to move here. I had the opportunity to come to Ivory Coast. Wow. And to set a Retina setting, and we started 3.5 years ago, and now we are doing modern surgeries here. Wow. In Africa with the same devices, with very complex cases, a lot of single eye, a lot of retracted retinal detachment, and a lot of glaucoma patients. So it's very challenging work here, but very interesting. Yes. And people are really, really great. So amazing. It's a new challenge.
Amazing. Well, congratulations. Congratulations. Let's talk about the work that you kindly agreed to come on the podcast for. It's an article that you just published in the Journal of Retina, and it's a surgical article. And for our listeners to know, it talks about perfluorocarbon use during vitrectomy for macula-Off retinal detachment versus essentially partial subretinal fluid drainage through the retinal tear. And it's a retrospective study. You talk about 80 eyes in total, and half of them had the drainage of the fluid through the tear,
and no retinotomy, no posterior retinotomy, just repair, and it sounds like you had some subretinal fluid left in the eye at the end of the surgery, and half of them used perfluorocarbon liquid to pretty much completely remove the fluid. And you would talk about the anatomical and functional outcomes of these eyes, and specifically you talk about metamorphopsia and how it's essentially similar, and you quantitatively talk about that. And so I was very interested to get your perspective on this because, as you know, use of perfluorocarbon is expensive, and we always deal with using it or not using it. And we may blame ourselves if we don't use it. Oh, patient could have had a better outcome if I'd used it. So your article is actually very interesting to kind of shed some light on this.
Yes, thank you for the introduction. Actually, in the surgical field, there's not too many evidence-based medicine papers, and we wanted to assess a little bit, our feeling, because we were the ID started in a meeting, and we had a panel, and the moderator asked who is using PFCL in every surgery. And
Yes.
around half of the surgeons were using it very frequently, and other very cautiously. So I was one of these surgeons using the PFCL for almost all the retinal detachment surgeries, because I really liked, the anatomical result with very fine fluid-free retina at the end of the surgery, and you feel more comfortable when you close the eye without any fluid. But I was not sure that it's really giving the patient an advantage in functional results. And when we started to think of this idea, we've seen that there are some papers already published showing that there's no increase in rate of surgical success with PFCL. And we all know the tremendous side effects of perfluorocarbon liquid. It's a great product since the late 80s, which we know that the high specific density and the low surface tension with the transparency is very useful for some cases like giant tears, when we have a choroidal hematoma, when we want to remove a lens from the eye. But we also know the drawbacks. The drawbacks are very annoying when we have some PFCL on the subretinal space, for instance, or that you have an increase in PVR rate, and you can have some inflammation. You have corneal decompensation when it's in the anterior segment. So we have also to be cautious. You also mentioned the cost. We don't think really about the cost in Europe because we have the social security, and we are not very interested in this aspect. But when I moved to other country, it becomes really a major aspect of our surgery.
Yes.
We have to improve our efficacy at the most effective cost. So we thought about this paper, and with the team, I want to acknowledge the team. You have Professor Gaucher and our Dr. Wurtz, that who designed the study, and we took very uncomplicated cases. We are talking about the classic retina off, macula-Off retina detachment with less than 1 week of detachment, and you perform your vitrectomy. You still have some fluid in the subretinal space. You have two options. You can remove it using a backflush, an active backflush by the retinal tear, or you can use the PFCL in order to remove completely the fluid. We don't usually perform some retinotomy in the posterior retina. This is not part of our way of doing. So we wanted to assess it.
Yes. Because in the place that I've trained and do these attachments, I commonly use a posterior retinotomy. So in your practice pattern, posterior retinotomy is generally not preferred because of obvious side effects, I imagine.
I use it in complex cases when we have PVR and I really want to perform some photocoagulation, laser photocoagulation.
Yes.
And I don't want any fluid beneath the retina. But in simple cases, I find it a little bit traumatic. It can give sometimes some
ERM, CME, those things,
and some epiretinal membrane. And if it's not necessary, I prefer to avoid it. Yes.
Yeah, fair enough. Fair enough. Yeah.
And what, as you said, it's very frustrating as a surgeon when you have your patient in front of you. You reattach the retina. You are happy of what you did, and he said, "No, I'm not happy because everything is distorted," and this was quite frustrating. And we thought that using PFCL would improve the symptoms, and actually, in the paper, this is not the case. We had the same rate of metamorphopsia in both groups. So we were quite surprised to see this aspect.
Yes, and which is interesting. And you also looked at the fundus autofluorescence and looked at the retinal displacement and retinal folds. And they also were the same, were not?
It was not statistically significant, but it was maybe even more marked in the PFCL group.
Yes, they had more of those displacements in the PFCL group.
Maybe yes, maybe if we had more patients, it would be statistically significant. But we didn't. It was not related to the rate of metamorphopsia. So distortion were related more to the presence of outer retinal fold. You have a lot of small signs on OCTs. Sometimes you can have some membranes. Sometimes you can have some retinal cyst. There's a lot of explanation, and sometimes you don't see anything at the fundus, but probably at the microscopical level, there's something going on with changes in the cone's orientation. Doing very light. Usually metamorphopsia and after retinal detachment, because we published another paper on this subject, are not really annoying for the routine activity of the patient. It's not. It doesn't bother the patient because probably because the other eye is compensating, so the patient can perform the daily activities without being very annoyed by the distortion.
Which is good. They get away with it. Yeah. So has this changed your practice? You said you were doing PFCL for pretty much every case. Has this finding changed your practice pattern since?
It's very interesting because it's one of the only studies I performed that really had an impact on my surgery. And now I definitely don't use PFCL in routine cases. I use it in very complex cases when we have giant retinal tear. This is mandatory for me because usually I perform in PFCL silicone oil exchange at the end to avoid the slippage. I'm quite conservative in these cases because I'm afraid of the very strong vitreoretinal proliferation sometimes going on in these cases. And usually when you have a very mobile retina that is, when you are performing your vitrectomy and it's not enough safe because there's too much movement, PFCL can stabilize a little bit the retina also. It can be helpful in these cases.
Yes. It's interesting as you're talking about the evolution of your surgery or change of your surgery style. I remember when I was a fellow, our chairman used to do these attachments that he always left subretinal fluid in the case. And I was panicking as a fellow. There's so much fluid in there. Why are we leaving the eye? And he said, "Oh, don't worry about the RP, will take care of it." And they all did fine. But when I started, I did a lot of retinotomies. I still do. But maybe as you get more experience and confidence, you do less of that and less of PFCL and more of just natural drainage through the existing tear and then face down position. Maybe that's the case for a lot of us.
Actually, we had one case of in the series of retinal fold, that necessitated a reintervention, and it was in the PFCL group. So this was also surprising because we position the patient face down for all macula-Off surgeries for 12 hours.
Yes.
And probably one of the patient did not respect the position, and he had like a fold coming completely in the middle of the macula, which was quite challenging to remove. So we had to go back to redetach the retina in order to reattach it.
Okay.
And,
okay, but the detachment was repaired except for the fold. They had to.
Yeah, it was completely. It was repaired, but with a fold, like with a very low vision. So we had to
redetach the
surgery.
Yeah. Yes. Yeah, interesting. And then in terms of success, they're essentially 95% or so similar. So you had 2 failures in the subretinal fluid drainage group and 1 failure in the TFCL group, which were not different, just 2 versus 1. I don't think that means anything between the groups. Can you comment on that, please?
Yes. No, there were no difference, but also in time of surgery, it's interesting to see that we don't lose time when you use PFCL, but we don't gain also time because sometimes when you stabilize the retina, it can be faster even if you have to remove the PFCL at the end. So we were around 40 minutes of the mean surgical time. Of course, with some faster case. We are talking about a simple case. Some cases need some cataract surgery, some combined surgery.
Yes.
But at the end, this is the usual success rate that was published in the literature in simple cases, I mean.
Yes.
And the cases that redetached were reattached with silicone oil in 100% of cases.
Yes, yes. Okay. Well, wonderful. Well, thank you so much. This was a very to the point article. Anything we talked about it, but any punchline you want our listeners or viewers to remember from your article, Professor Saleh?
Well, I will say you never stop to learn and to change your practice.
Yes,
this is the most important thing. I think we have to say agile, as we say in French.
Agile.
Agile.
Which means what?
It means you are moving fast, and adapting fast.
Adapting fast, staying alive.
Exactly.
All right. Well, wonderful. Well, thank you so much for coming to the Retina Channel podcast. I really appreciate it after a busy OR day.
It was a pleasure,
practice.
Dr. Kishan.
I enjoyed interacting with you, chatting with you, and I wish you all the best in the new phase of your career in West Africa, and all the best success in the future.
Thank you. For you too. It's a great idea to have this podcast. Thank you again.
Thank you. Thank you.
All right, folks, this wraps up episode 82 of the Retina Channel podcast. I want to thank Dr. Saleh for joining me from West Africa and telling us about the finding of this wonderful article about the use of perfluorocarbon heavy liquids on the effect of metamorphopsia after retinal detachment surgery. It makes me wonder if we really need to use perfluorocarbon heavy liquids in every retinal detachment. And thank you for listening to this episode as well. Until our next episode, I wish you all the best. Take care and see you then.